Good morning, everybody. We thank the Egyptian Veterinary Society. We'd like to thank Dr. Ahmed Mustafa and the Society of Continuous Ophthalmic Education for inviting us to arrange this symposium. This symposium is on facts and myths in the management of diabetic retinopathy. We are going to start by the talk of Professor Magdi Musa on the role of multimodal imaging in the management of diabetic retinopathy.
Thank you, Dr. Khalid. Good morning, everybody. Thank you, Dr. Ahmed Mustafa, for the kind invitation. And I hope we had no hard feeling for the talk we spoke about today. He's one of my best friends. Today, I'm talking about the role of multimodal imaging in management of diabetic retinopathy and diabetic macular edema. We all know that there is a big role in imaging for management of diabetic retinopathy and diabetic macular edema. Start by identifying diagnosis of this patient had diabetic retinopathy or not. Second thing, classifying, is it proliferative or non-proliferative? Third thing is quantifying the amount of macular edema to start treating this patient. Then to specify the treatment modality, and again, it depends on OCT, and then clarify visual prognosis. The first question is, what is my prognosis? And the follow-up after anti-VEGF treatment or any surgical procedure, and then when to switch or when to stop treating this patient. Let me give you quick examples for this. To identify or to diagnose, we can see the fundus picture or examine the patient by biomicroscopy and look at him, and then classifying as diabetic retinopathy. Which stage? If I give you this picture, you might say it's a non-proliferative with a severe ischemia, and there is IRMA, so this is a severe non-proliferative. But again, we have to look again at the periphery, and there is neovascularization, so we can change the classification by looking at the center and the periphery into the proliferative diabetic retinopathy. Quantification. If I look at the patient and say, this is a cystoid macular edema, but how much thickness in the macula? This is the quantification we need before start treating the patient. Third thing is specifying treatment modality, and we all know that we have nowadays new classification, center involving and non-center involving, and this is completely different because in non-center involving we can observe, we can treat by laser, but in center involving nothing else but anti-VEGF. Second thing, the vitreoretinal interface. If we have traction like this, we never start by injection and we have to start by surgery. So classification is very important. Knowing what's going on the vitreoretinal interface is very important. Third thing, vitreoretinal interface abnormality like vitreous separation, like the first picture, and the lower two pictures showing vitreomacular traction. So this is completely different. Nowadays, we are not afraid of vitreomacular adhesion like this because injection can release the adhesion and we can continue injecting this patient till getting the macula dry. But looking at the patient like this with a vitreomacular traction, thick posterior hyaloid, intravitreal injection is contraindicated and we need to do surgery for this patient, and we get good results by these cases. Keep injecting these patients. One by one, we might end up in a macular hole, and this is contraindication for injection when we see a thick and taut posterior hyaloid. Third thing, imaging in diabetic macular edema. We need to know the prognosis. The prognosis depends on outer layers and inner layers. The outer layers including the external limiting membrane and the inner segment, outer segment junction. And the inner layers, disorganization of these inner layers is a very bad prognostic factor, and we will see a couple of examples. This is an example of disruption of the outer layers including the external limiting membrane and ISOS, which mean there is disruption of both these layers, which is a very bad prognostic factors. How about large cyst with disrupted molar fibers, another bad prognostic factor, and this disruption might lead to permanent visual loss. What is the drill? Disorganization of the inner retinal layers, and it's mostly due to ischemia of the deep capillary plexus, and we can see on the left side, we can differentiate the retinal layers. On the right side, there is no differentiation. I cannot differentiate the retinal fiber from the ganglion cell, from the inner plexiform, from the inner nuclear layer. So this is another bad prognostic factor, and we have to look at this carefully, and this is another bad prognostic factor. How about the perfusion, the macular perfusion? We used to count on fluorescein angiography, but nowadays we can see that OCTA can replace that because it has a very nice, precise details detecting the ischemia. As I said, in the old days, we used to depend on the central area, how much ischemia of the macula, how much ischemia of the periphery on fluorescein angiography. And this was unreplaceable because this is the only way to detect ischemia. But nowadays we had OCTA, which is more clear and precise. Like this case, we have ischemia in the center at the level of the superficial and deep plexus, and we can differentiate the ischemia from the cyst by the en face OCT. So again, we have another tool which can detect the ischemia from the cystoid macular edema. How about wide field fluorescein angiography? Why do we need it? Because sometimes looking at the central area up to 55 degrees, it is not conclusive. Looking at more and more at the periphery, we can find out how much ischemia is there, and we are missing this. We can change even the diagnosis from non-proliferative to proliferative if we look beyond the arcades. So wide field is very important in these cases, and it can tell us how much ischemia at the periphery, which sometimes we ignore, and it is the cause of recurrent diabetic macular edema. Sometimes we do laser, and we think this is adequate laser, but sometimes this laser is not adequate because we missed a lot of things in the periphery, and that's why the new vascularization is not regressing. How about wide field OCTA? Nowadays, it is available to have a 12 by 12 millimeter OCTA. Looking at the arcades and beyond the arcades, we can see the NVE, but we need to go more peripheral, so we can combine two 12 by 12 millimeters, and we can get up to the periphery, and it can give us a very good idea if So it gives us a very good idea, and we can have a very good idea about the periphery in 1 or 2 scans, which is non-invasive, and sometimes when fluorescein angiography is contraindicated, we can rely on OCTA. Sometimes we get a dark media like this and a very dense media opacity, so fluorescein is not showing a lot of things, but OCTA of the same patient can be conclusive because OCTA sometimes with the swept source can penetrate deeper through the cataract and give us a very good idea about where is ischemia, where is neovascularization. As I said, classification depends on center involving and non-center involving, and it is an OCT classification. We never look at the fluorescein and say this is a center or non-center involving because OCTA is the only clue in these cases. What else? We can follow up this patient looking at the fluorescein and OCT, and this is an observation case because the vision is not affected yet. But once we have cystoid edema, hyperreflective foci, sensory detachment, we all know that injection is a must in these cases. What is the role of OCT again? Following up of these patients, we have a baseline thickness, we have a baseline morphological information, and then we can follow up, and we will know that this patient is a very good responder. What is the meaning of responder? That he responds up to 40% from the first 3 injections. Poor responder, 10% reduction, or non-responder, there is no percent, 1 to 2%, which means we have to change our treatment modality. So looking at the map, this is a very good responder because the thickness decreased after the 3rd injection, or we can keep injecting. Sometimes we inject once, twice, thrice, and then still the macular edema is there. So we would know that this patient is not a responder, and it's an OCD-based classification. So we have to change our strategy. If we give 3 loading dose, sometimes we have to stick to more and more injections until the macula respond, and some of the patients had to be switched to another type of anti-VEGF to find out the result, and we can switch from one to another, as I show in these cases, and it is available in the clinical practice. And when to shift to steroids, we have specific indication when to shift to steroid. Non-responder after shifting to another anti-VEGF, pseudophakic when started by steroids, and diabetic macular edema sometimes with epiretinal membrane, which we're afraid to increase the thickness. So this is a patient with multiple injections, 3 anti-VEGF. We shifted to another anti-VEGF. The edema is progressing, and we shifted to steroids, and we get a very good result. So at the end of my talk, I can say that fluorescein and OCT are still the keystone, the gold standards in the diagnosis and management of diabetic macular edema and diabetic retinopathy. Wide field fluorescein is very important to detect what is going at the periphery, because sometimes the periphery is the clue of recurrent diabetic macular edema and the amount of ischemia there secreting more and more VEGF. OCTA technology, it's a very new technology, but it's a very promising. It can give you the extent of macular ischemia much more than fluorescein, and it can also reach up to the equator, and we can have a very good idea about the periphery, and it is sufficient enough to replace fluorescein. And I think in the future it will happen when we get more and more wider and better resolution. And OCTA combined with structural OCT is comparable to fluorescein, but again, as I said, the standard of care is fluorescein and OCT in the management of diabetic macular edema. Thank you so much for your listening.
Thank you, Dr. Magdi, and I have just one question for you. We'll have the floor open for questions at the end, but for you, I just have one question, because this is, it's kind of an educational session. So You've shown nicely a lot of modalities of the imaging that we have currently for diabetic retinopathy and other diseases. But if you have a patient presenting to you with diabetic retinopathy that you can't really stage, I mean, at a certain level of the learning curve of how to diagnose a patient, and you have those background hemorrhages, hard exudates, microaneurysms and stuff, would you tell me exactly what would you ask for this patient? I mean, would you go for OCT plus fluorescein, OCTA and structural OCTA, or just fluorescein? What would you do?
The clear message is fluorescein and OCT at the baseline. I never order OCTA except in a very limited, I mean, this is a message. So start by fluorescein and OCT. OCTA is limited if you cannot do fluorescein. If you are not explained what you see by fluorescein and OCT, you might order OCTA because sometimes you find the vision is not correlated with what you see. Sometimes I ask for OCTA, and this is another clue. If you have sometimes older patients, you might have combined CNV sometimes with diabetic retinopathy, and OCT is the clue in these cases.
Okay, one last question to you also. Do you depend or rely on OCTA in decision-making for treatment of diabetic macular edema? Or not?
This is a good question, but he means by OCTA, OCTA, because we all know that once we do OCTA, we have a structural OCT with it, right? So
I mean, would you order an OCTA for a patient with diabetic macular edema to guide you in the decision-making for the treatment?
I already ordered OCT, but OCTA specifically, no.
Okay, thank you.
Thank you.
Okay, next presentation is by Mbabi, treating the 10 Commandments of the RCR.net. Thank you, Sharif.
Okay, good morning, Mr. Chairman, Mr. Moderator, dear colleagues. I would like to thank the Egyptian Society of Continuous Ophthalmic Education for the invitation of the EGVRS to participate in this prestigious meeting. I'm going to talk about the 10 commandments of the DRCR.net. Okay, so just the importance of the disease, diabetic retinopathy, that nearly 1 in 20 people on this planet has diabetes mellitus. So it's a very common disease and epidemic. And more than 95% of people with diabetes will develop some form of diabetic retinopathy if they live long enough. And again, diabetic retinopathy, we have to stress again, is the leading cause of new onset blindness among the working age group, which is the active group between 25 and 65 years old. So how frequent you treat diabetic retinopathy? Most probably everybody in the ophthalmic community, they treat diabetic retinopathy, whether it's a general ophthalmologist or retina specialist. So everybody treats this disease. So at least we should have good information about this disease. We have a lot of problems with like lack of public awareness. Patients don't know that diabetes can affect their eyes. Lack of public media. They talk about other procedures. They don't talk about diabetic retinopathy. Lack of government policy for screening. And lack of role of the internist as well and diabetologists to make the patients screen their eyes. This is a big problem in Egypt and in the Arab world. And other problems with the ophthalmologists as well, we have undertreatment, we have overtreatment, we have delayed treatment, we have non-indicated drugs, lack of knowledge of clinical trials, use of clinical trials as cookbooks, lack of knowledge of imaging, as Dr. Magdi was just mentioning his presentation, we have to know how to read fluorescein, OCT and OCTA, and when to use them. And at the end, we have erratic treatment for those patients. So we end up with many patients in their 20s and 30s presenting with advanced disease, with advanced PDR, for example, and they turn out to be blind. And that leads to loss of manpower and also a financial burden on individuals when they start to treat the disease so advanced. So what are the 10 commandments of the DRCR.net? I'm going to just mention this morning. First of all, looking at the OCT, the relationship between OCT measured central thickness of the macula and visual acuity in diabetic macular edema is very strong, moderate, or modest to poor. There is modest correlation between OCT measured center point thickness. So we think that a thick macula is usually associated with a poor vision, but this is not necessarily the case. So there's a wide range of visual acuity may be observed for a given degree of retinal edema. So we always look at the patients as at an OCT. Sometimes we never look at the visual acuity. Sometimes you have a patient with a 500 micron central macular thickness and a visual acuity of 0.8 or 0.9. So although OCT measurements of retinal thickness represents an important tool in the clinical evaluation, they cannot substitute reliably as a surrogate for visual acuity at a given point in time. So always measure the visual acuity for every patient that you are treating. The second commandment is comparing focal grid photocoagulation and intravitreal triamcinolone for diabetic macular edema. We have the myth that steroids are magic and you can treat all types of macular edema. So again, is IVT more effective? Is focal grid more effective? Or both are equally effective? And this was mentioned in 2009 by a trial that was done by the DRC, and there was no long-term benefit of intravitreal triamcinolone relative to focal grid treatment in patients with diabetic macular edema. And actually, focal edema is even superior at 3 years than the steroids, the intravitreal triamcinolone. You may get a short-term benefit, as you can see in the arrow over there, but again, at the end of 3 years, you get that the focal grid laser is better. So IVTA, don't use it as a primary treatment, please. So what are the current indications? The third command, current indications of anti-VEGF agents in DME, is it central involving, non-central involving both entities? We have to stress that the current indication of anti-VEGF is only in central diabetic macular edema. We cannot tell for sure if it is effective in non-central involving diabetic edema or not, because there are no trials to support this. What about medical treatment for recent vitreous hemorrhage? We see a lot of treatments. I see a patient having a vitreous hemorrhage. He's taking alfentern, ambizeme, alpha-chymotrypsin intramuscular injections, and he keeps searching the pharmacies for this magic intramuscular injection. Doxium, do we use all of this, any of this? There is no medical treatment for diabetic vitreous hemorrhage. Please, 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 please stop those non-indicated drugs. I see many professors, many specialists, retina and non-retina, and they still write these drugs. I don't know from where they get this piece of information. Please don't use them. Just throw them in the dustbin in your office. Is there a long-term benefit of intravitreal anti-VEGF in vitreous hemorrhage? I have a patient coming to you having a vitreous hemorrhage, never had laser, and the first thing that the doctor says to him, I'll inject you with Lucentis or Eylea or Avastin or whatever. Do you have support for this? There was a randomized clinical trial evaluating intravitreal ranibizumab or saline for vitreous hemorrhage. In cases of proliferative diabetic retinopathy, there is little likelihood of a clinically important difference between injecting anti-VEGF and saline. And the rate of vitrectomy by 16 and 52 weeks in eyes with vitreous hemorrhage from PDR was equally just the same. So if you inject just saline or anti-VEGF, it's the same. So don't use them for treatment of vitreous hemorrhage unless you are preparing the patient for vitrectomy or as a complementary treatment with PRP. What about the risk of macular edema after cataract surgery? When you discuss this with a patient without preoperative central involving diabetic macular edema, is there a risk if you do a cataract surgery for those patients or not? So eyes with history of diabetic macular edema and or treatment immediately prior to cataract surgery are at higher risk for developing centrally involved diabetic macular edema. When? Usually at 16 weeks after cataract extraction, than those with no history of diabetic macular edema or treatment for diabetic macular edema. These data may help physicians to explain the risk of diabetic macular edema progression after cataract surgery to their patients, tailored according to the level of DME and history of DME. So the patient may develop diabetic macular edema centrally involved about 3 months after the surgery. What about repeated intravitreal injection of anti-VEGF? Does it affect the intraocular pressure? We always have the notion that steroids only increase the intraocular pressure. But again, there is a repeat intravitreal injection of ranibizumab were associated with an increased risk of sustained elevation of intraocular pressure. And this usually appears after an average of 15 injections over 3 years. So keep an eye on the intraocular pressure for those patients. They are not always, they can develop elevation of intraocular pressure. So this data suggests IOP should be monitored periodically in eyes receiving repeat intravitreal injection of anti-VEGF. Number 8, what about the 5-year outcome of PRP versus intravitreal ranibizumab? Now people are trying to avoid PRP, but is this the best thing for patients in Egypt? Should we only inject ranibizumab every month or every 2 months with the cost and the compliance and the risks of infection? Although there is a loss of follow-up and was relatively high in this study, but however, the visual acuity was almost the same at 5 years in both groups. So we have to tailor our treatment about the compliance, the cost, and the frequency of the visits. So again, I think PRP still is the most appropriate way to treat PDR in patients in Egypt. Thus, the addition of intravitreal dexamethasone, as Dr. Magdi was saying, provide benefits to eyes receiving continued intravitreal ranibizumab therapy for persistent diabetic edema. They found that there is an improvement in thickness, but the visual acuity barely improved because you always bring steroids very late in the disease when there's damage of the photoreceptors. So again, yes, you can see in the graph, the thickness is better with the steroids, but however, the visual acuity is just the same. whether you inject or don't inject. So if you want to bring steroid into treatment, please bring it earlier when you have refractory edema, but after 3 injections or 6 injections after switching, as Dr. Magri just mentioned. What about the clinically meaningful difference are unlikely in OCT thickness or visual acuity following application of PRP in one sitting compared to 4 settings? Sometimes when you have a patient with PDR, and I see patients, they told me I had PRP over 5 sessions, 6 sessions, 7 sessions, bringing the patient every time for just few spots. They found that there is no difference at the end. So you can deliver your PRP in just one single sitting if you can, if you like. There is no problem. There may be transient edema in some patients, but at long term, they are just the same. I'm just going to have a look at some few cases. This is a patient, 40 years old. You can see this is the OCT of the patient. You have cystoid macula, significant thickening, okay? You can see this. If you look at the OCT, the first thing you say, okay, I'm going to treat these patients because the center involving, it's a cystic edema. Treat or not to treat? What do you look for? Vision is 20/20, well controlled. Again, this is 1 year later. You can see there's an improvement in the thickness. We did nothing to this patient, nothing, just observation. Again, the trial that discussed all the anti-VEGF treatment, they were talking about patients having less than 20/30 vision, not 20/20 vision. So again, when we have a patient having excellent visual acuity, you have to think about whether to treat or not to treat, and Dr. Ahmed Suka will cover this topic after me, so I will not discuss it now. So another case, again, this is a patient having cystoid macular edema, diabetic macular edema. Again, we have a lot of trials saying a lot of loading doses. Again, should we inject 3, 4, 5 PRN? Again, you can see one eye had I treat my patients with PRN. You can see that there is, in the left arm over here, we just injected once and it stayed dry for almost 1 year. The other eye required a lot of injections. So again, there's a difference between one eye to another. It's not a cookbook. I just want to show final thing before I end my talk. This is a case of PDR. You can see the extensive NVEs and the NVDs, okay? This patient, again, this is the OCT. This is how it looks. This is after PRP in a single sitting. And again, there was no development of macular edema. I'm not going to discuss more than this. I just want to say thank you so much for this opportunity. And I want just to remind you about the upcoming EGVRS. Just one slide, just to say thank you. Yes, just to remind you about the EGVRS. Can you show just the last slide? We would like to welcome you in April. That will be held in Aswan. And we hope that we can see you over there. Thank you so much.
Thank you for the book.
Not the usual case, but you can see them in some cases.
Yes, in some cases. But as a guideline, if you have a cystoid edema 400, 6 vision, and the patient is complaining, would you treat or not?
Still questionable. I think Dr. Ahmed Suka will answer this question.
No, I'm asking you.
6 vision?
Yes.
I will not treat. I will not.
Complaining, not quality.
No. Control your blood sugar. Come after 3 months.
Listen to Dr. Ahmed. Thank you.
Actually, I wouldn't look for a better introduction for this talk. It's exactly this question and exactly the introduction of Dr. Sharif. Today I'm going to discuss the protocol V results, which is addressing this point specifically, symptomatic or not, visual acuity better than 6/9, very complex situation. And unlike what we thought before, it's a very common situation because of screening patients in Egypt specifically by OCTs whenever they have diabetes, and we're looking at the fundus, they look good, they're 1.0 vision, 6/6. Everybody does fluorescein and OCT, and oops, they have macular edema. It's a problem, really. The DRCR guiding us through diabetic patients, marvelous randomized controlled studies, protocol V addressing this issue specifically, looked into the issue because previous trials started recruiting patients when they have visual acuity of 6/12 or less. It wasn't aiming that we will not treat patients having 6/6 or 6/9 vision, but it was the recruitment plan only. So the results were very nice, very specific, but did not address patients of 6/9 vision, 6/6 vision. So they started looking into this. Why? Because in EGVRS previously, they had lots of cases actually with high visual acuity included in the trial. And they were either observed or lasered at the time. And you could see that laser was a bit better because only 27% of these patients lost 5 letters instead of observing them, and in 40% of patients you lose the 5 letters. So it's a lot of patients. Giving laser goes down to around 27%. Looking at some high visual acuity patients in the DRCR protocol I cases, this dropped to 5%. So what were our strategies that we could think of when we meet these patients? Either we'll give injections and treat the edema to get rid of it, or we might give laser and observe the patient. If it is worse, then we start injections, or we simply observe the patient and look for this drop in visual acuity, and then we start our injections. These are the 3 possible strategies when you meet these patients. Here, we are comparing if we give the laser to simple observation, because the question whether laser will be better or not was not still answered. Recruitment of patients in this fashion, as we mentioned, and the regimen in real life is observing the patient. This means monitoring and visiting, looking at visual acuity, and we rescue by anti-VEGF, or giving the laser and still monitoring the patient and looking at visual acuity every 2 months and giving injections when it drops. Or he's complaining, maybe we don't like the edema, start the injections and let's see. Important is to remember, you have to monitor visual acuity, and it's not OCT, it's only visual acuity. This is a burden that's off. You don't do OCTs regularly, you look at the vision only. And never give a laser and stop monitoring and think that everything is fine. How about the results of these recruitment strategies? All 3 groups, by the end of 2 years, did not lose vision more than any other, meaning the 3 strategies do not lead any one of them to worse patients. So you can do the 3. Any one of them is okay. How did the vision fare over the 2 years? Well, by the end of 2 years, nothing was significant. The 3 groups using these strategies was okay. However, at 1 year, it was significantly better vision statistically when you start the injections early, meaning that these patients spent 2 years seeing better than the ones who were only observed until they drop and injected, or lasered until they drop and injected. So still questions remain. However, you can delay your start of treatment until the visual acuity drops, because there is no loss of vision by the end of 2 years if you do that. So you do not have to treat these patients. Monitoring is the important thing, and you do not tell the patients that your strategy is not injecting. The strategy is actually that we will inject when you drop in visual acuity and it becomes significant. So the hallmark is monitoring and visual acuity only. How did they look, these patients? Of course, injected patients early had better anatomy because they were simply injected that early. Observation groups and laser groups, by the end of 2 years, was similar in vision and anatomy. Why? Because the ones who had significant drop in vision were also injected, and the anatomy was improved also. And some minority had drop in the thickness without even treating, as Dr. Sharif presented in one of these cases. So why is it similar? We just discussed it. And leaving them without injections was not the cause of improvement in anatomy. It's because some of them were selected and injected. Okay, another question comes up. Maybe, if you give laser, for example, and you wait, and the one patient still has a drop in visual acuity, worsening of the edema, and you start injecting, maybe you use here less number of injections because of the previous laser at the beginning of this monitoring period. All patients who needed injections along the 2 years because of this visual acuity drop, or if you decided from the start to inject from the start, all of them received the same average number of injections over the 2 years, 8 injections in average. So actually, using any strategy did not lead to less number of injections, even if you add laser at the beginning. So this is my summary, and the previous slides were all the RCR slides. The 3 strategies are not causing loss. Okay, fine. It is not a monotherapy, meaning you don't give laser and say this is the treatment of the edema. You are monitoring for the drop, and if it happens, you add your injections. Observation alone can end in injections if they drop. Most eyes in the observation group and the laser group at the beginning did not need injections, most of them. 3/4 of the laser group and 2/3 of the observation group, without statistical significance between both. This means that if you inject all patients, more than 2/3 of them are unnecessarily injected. They would have stayed in the 6/6 area, 20/25 area, even without the injections. 1/4 to 1/3 of them will need the injections over the 2 years. Another question is laser. It's becoming more useless because it did not cause statistically significant more patients not needing injections, so we did not benefit here. It did not even reduce the number of injections if the patient needed them, so it didn't introduce anything. It actually had no use over the observation group. In my simple conclusion, if the patient is asymptomatic, you choose a strategy of observation. And when the patient drops in visual acuity to 6/12 or less, you start your injections. And it would be the same number of injections if you started early. But if the patient is complaining, because I have patients who could not function normally, although they are 6/6 in my clinic, but they are the ones complaining and saying, I'm not reading well, I'm not working well, I'm not happy. These ones I do inject because it's the same number of injections, but they lead a happier life over the 2 years. Why would the patient be sometimes symptomatic or not? Because we are screening patients with OCT even if they are not complaining. And that's the point where you find the macular edema, although the patient was not complaining. At this point, I would say observe, look for the progress over the 2 years only by vision, no more OCTs, and when they drop, you inject. This is the publication of the RCR, and all these results are the RCR protocol V results. Thank you.
Thank you, Ahmed. I have a question for you. This is an excellent protocol by the DRCR-NET, and I think this is maybe the only protocol that favors the visual acuity over the anatomy of the macula in decision making for treatment of diabetic macular edema. And in real life practice, you see a lot of our colleagues who treats patients based on just OCTs, okay? Mm-hmm. And like Dr. Sharif just emphasized in the case that he presented, that you can have such a huge edema with a very good visual acuity. So it's important to deliver the message that we have to check the visual acuity of the patients, not just the decision of the one who writes the report of the OCT. This is center involved diabetic macular edema with such a thickness, so it goes directly to maybe a general ophthalmologist or someone who is not a retina specialist, and he just inject the patient unnecessarily. I'm not saying he's harming the patient, but if anything goes wrong, like endophthalmitis or other complications of injections, I think this could have been avoided.
Of course.
Right?
Yeah. The message here would be simply that you inject lots of patients with different diagnoses, meaning diabetic macular edema is one of them, another is RVO, vein occlusions, and another is AMD, CMVs. The most diagnoses, like AMD and RVO, depend on OCT, and you have to reach dryness on OCT, and it's simple to follow the OCT. Diabetic macular edema is different. There is discrepancy between your targets. The vision is the target and not the edema. You have patients who did not change in macular edema, but they had improvement in vision, significant and clear. The target is not total dryness in diabetic macular edema, unlike the other pathologies. So it is a bit complicated, but it is dependent on visual acuity much, much more than the OCT, of course.
Can I have a quick question in 1 second? 1 second.
Yes, okay. تفضل.
Dr. Ahmed, you said if the vision drops, you start injecting.
Yep.
And I agree with that totally. But in between the lines in the paper, would you start injecting PRN or start injecting the 3 loading dose?
The injection protocol is the same, whatever the situation. It's very similar to protocol T. Yes, of course, you load here, I load 3. Actually, the RCR suggests more, 5 to 6 actually. But most of us are practicing 3 initial loading. Yes, I give the 3, of course.
Once the vision drops.
Yep.
Thank you.
At this point,
I'd like to have a pause to address. هتكلم بالعربي. أنا الحقيقة عندي a little bit of concern إن إحنا جمعية الشبكية the Egyptian Veterinary Society are talking more specifically in a more specialized points. لكن هم they are not. إحنا اخترنا الموضوع ده لأسباب كتير. الموضوع ده كلنا مفيش حد حتى لو كان مش متخصص في الريتينا مفيش حد ما بيقابلش diabetic retinopathy ومفيش حد ما بيتحيرش في مواقف كتيرة فإحنا اخترنا المواقف المحيرة. ومفيش حد ما بيحنش احنا اخترنا المواقف المحيرة وهي محيرة فعلا and we try to solve a little bit الconfusion اللي هو كتير جدا منه ما تحلش نهائيا. مثلا نمسك اخر توك الدكتور احمد سوكا هو coined الكونكلوجنز بتاعته بسوكا his own conclusions. انا I tend to agree with what he said. مثلا لما بنقارن ما بين الأوبزرفيشن والإنجكشن والليزر نلاقي at the end result زي ما الدكتور أحمد شرح لنا هو اختياره إن احنا to observe. ليه أنا بوافق على الفكرة دي؟ بوافق على الفكرة دي لأنه الاختيار احنا مش بس بنقيس الإند ريزلت في الثيكنس وفي الفيجوال اكيوتي، احنا كمان لازم نقيس البردن اوف ذا تريتمنت اون ذا بيشنت. احنا ما فيش مقارنه ما بين الكوست اوف اوبزرفيشن والcost of laser والcost of injecting repeated injection in a patient who has 6/6 vision. This has to be put in mind. And I'm happy that your conclusions also, maybe you didn't say it, but it is, I'm sure it is on your mind. النقطة اللي قالها الدكتور شريف كلها كانت هي فيها فعلا كونتروفيرسي كبيرة جدا بنقابلها كل يوم. يعني نعمل ليزر ولا ما نعملش؟ فوق الليزر ده له مكان ولا ملوش؟ الديسكشن دي موجودة لحد النهارده. الدايابيتيك ماكيولر ايديما افتر كاتراكت سيرجري ده كلنا بنقابله. طب نتصرف ازاي؟ ده احنا بنشوف ناس بيمتنعوا ان هم يعملوا كاتراكت سيرجري because there is some incidence of diabetic macular edema afterwards. طبعا ده مش الدكتور شريف وضح لنا ان this is not a wrong concept. وامتى ممكن يحصل الدايابيتيك ماكيولر ايديما نعالجها ازاي؟ دور الكورتيزون as compared لدور الانتي في جي اف، دور الانتي في جي اف وعلاقتهم بالجلوكوما، الحاجات دي كلها we see in the practice of our colleagues even among retina specialists we see differences. وبالتالي انا مش عايز الاودينس يبقوا very much confused او يعتقدوا انه الدايابيتيك ريتينوباثي ده عباره عن الغاز. in fact we chose الحاجات اللي فيها يعني controversy وملغزه وبنقول راينا. so far I hope ان الامور تبقى clear. I hope by the end of the session we open the floor for discussion لانه الدiscussion بتوضح اكتر النقط اللي فيها confusion زي دور البي ار بي مثلا زي ما شرح الدكتور شريف. احنا بنتكلم في نقط كلها فيها confusion in an area which is very important not only for the retina specialists but also for the general ophthalmologist. دكتور مغازي من فضلك.
Okay, thank you, Dr. Khalid, and I'd like to thank the Egyptian Society of Continuous Ophthalmic Education and Dr. Ahmed Mustafa for his invitation. I'd like to thank the board of the EGVRS as well. My talk today is about the treatment response and what to do next in a patient with persistent diabetic macular edema. So, a persistent diabetic macular edema, by definition, is the one that is failing anti-VEGF treatment, which is the first line of treatment and the treatment of choice, and actually the gold standard for the treatment of diabetic, currently for center involving diabetic macular edema. In general, the target of any treatment in diabetic macular edema is to dry out the macula and improve visual acuity, and response is different from one patient to the other. And without going into the complex multifactorial nature of diabetic macular edema, in general, we have good responders, partial responders, poor or non-responders, and all of these are present in our clinical practice every day. In general, the pathological stages in DME, or the DME passes through stages, so from early focal leakage to loss of photoreceptor cells. And during those different stages, there is a difference in the chemistry going on inside the eye. from different immune modulators and different inflammatory mediators found in the eye, from the VEGF-mediated vascular permeability factors, like the VEGF, of course, and the other, on the other side, the chronic inflammation and the other inflammatory factors that all increase vascular permeability and lead to the chronicity of the edema. So we all have seen this in clinical practice when sometimes anti-VEGFs are not working at all in some patients like it does in others. So probably this is just a hypothetical that those patients where the anti-VEGFs are working maybe have a more VEGF-dependent diabetic macular edema rather than those with non-VEGF dependent edema which do not respond to the regular anti-VEGF therapy and maybe need a different way of thinking or different guideline of treatment. So one of the unknowns in treating diabetic macular edema is whether or not initial therapy with an anti-VEGF agent will produce the expected positive outcome in a particular patient. With an absent reliable early predictor, clinicians begin anti-VEGF treatment, knowing some patients will have an inadequate response, signaling the need for a different course of treatment. And to date, however, there has been no definitive guidance regarding how many anti-VEGF injections should be administered before a patient is deemed a non-responder. Just to help answer such a question, there is a group called the Early Analysis Group, and it's formed from very well-renowned medical retina consultants in the States and Europe, and just trying to answer that question. So this is a graph from the protocol I, the RCR-NET protocol I, and you can see that the most visual acuity gain were those patients receiving Lucentis with prompt laser. With steroids, patients receiving triamcinolone and prompt laser initially having a good response, and then the response failed, and this probably or was attributed to cataract surgery. So this group of early analysis group, they took those patients with ranibizumab plus deferred laser and those with prompt laser, and they divided the response into those with limited response, intermediate response, and strong response. Actually, to my surprise, the majority of patients, 39.7%, did fall into the poor responders category, and only 37.1%, let's say 1/3 of the patients, did show a good response or more than 10 letters improvement. And this is actually, if you go through any of the randomized clinical trials, these will be the numbers. It's only 1/3 of the patients actually who gain those more than 10 letters. And the other majority, they usually fail the treatment or they do not show such a good response. This is just a graph of the poor and the intermediate or partial responders and the good responders. You can see that after the initial 3 loading doses, if you call it loading doses, I don't believe in loading doses, but if you call it so, after the initial dosing, all the responders, they swim in their own lanes, like they say. So the good responders usually remain good responders, and the poor responders usually remain poor responders, with few exceptions in each arm. I'm sorry, I need to go back. From the poor responders, only 23% of the poor responders with repeated injections, they did not reach to the good response level, but still they showed some improvement. This is only 23%, a small minority of patients. There is no way to know who are those patients, and if you continue with one patient, if he can actually reach that or not. So, to conclude, the post-hoc analysis in Protocol I data showed that best-corrected visual acuity response after 3 anti-VEGF injections at 12 weeks is a strong predictor of long-term best-corrected visual acuity response in most of the cases, not all the cases, of course. And early response remains a significant predictor of long-term behavior, even after adjusting for baseline characteristics. So, what to do next? Most of us would think about an alternative therapy when faced with a poor or no response, or after development of what we call tachyphylaxis or tolerance, which is initial good response and then the response fails. So what would you do? I think you would think about switching. You go to another kind of treatment. However, you have to wait. Why to wait? I mean, don't just take the 3 injections and say, well, the patient is not responsive. Why wait? Because 9 to 10% of ranibizumab-treated eyes were delayed responders in the RESTORE trial. And also in the RESTORE trial, some of the patients who initially lost vision, they continued to improve and gained an average of 11 letters at 12 months. Also, in the delayed responders in the RETAIN study, they also showed some improvement in spite of initial loss of letters at the beginning. This is also from a post-hoc analysis with the VIVID and VISTA, showing that continued treatment can result in some improvement anatomically and vision-wise. So the thing is, you have to give it some time. I mean, I don't switch after 3 injections. You have to give the patient some time. Maybe he is a delayed responder. You have to correct for other factors that might be delaying the response, such as systemic control of the blood sugar and others. But the question will always remain, till when? Well, it's up to your own judgment. However, usually I don't prolong the injection of anti-VEGF more than 6 injections, and then I think I have to switch. And the other, I'm sorry. So what to do next? I think we have to switch. What to switch to? This is again the $1 million question. So is it another anti-VEGF? I think most of us at the moment, this is what we will do. So if you start with Lucentis, you would say, well, why don't I give him a shot with an Eylea? Maybe there would be a response. So this is a very nice analysis in 2017, and it's showing a lot of case series and case studies in patients who have switched from one anti-VEGF to the other. This is from Avastin to Lucentis, and this is from Lucentis to ranibizumab. And the conclusion is most of those patients did not show any meaningful improvement in visual acuity. However, they showed some dryness of the macula. There is a limitation, of course, for those studies. They are retrospective, small number of patients, and short follow-up. So what to switch to again? So you injected one anti-VEGF, you switch to another anti-VEGF, and there is no response again. So again, you need to switch. So what to switch to? What about considering a totally different class of pharmacotherapy? This is a really interesting graph from the Rise and Ride, and showing those patients who were not injected anything, those the sham injected people who are allowed to receive Lucentis at 2 years, and those patients by 2 years had chronic edema, and when they were given Lucentis, they did not improve, they did not show any similar improvement or any near improvement to the patients already enrolled from the beginning when they were the edema was fresh. So in those patients, the chronic diabetic macular edema patients, I think the other inflammatory mediators that apart from VEGF are prevailing. So we have intravitreal steroids, we have now the Ozurdex, the Iluvien, and the triamcinolone has always been there. And again, this is a graph from Protocol I, and you can see if you correct for the cataract, these are the patients with pseudophakia, and you can see the improvement is almost as with the ranibizumab arm. This is from the FAME trial for the Iluvien, and those patients actually showed improvement. This is from the Ozurdex, and actually those patients, again, if you correct for the cataract, those are the pseudophakic patients, and those are chronic patients. Remember, they did show some improvement. And this is the breakdown of the patients with previous treatment, whether laser or anti-VEGF, and there is an actual improvement, but only, however, in 28%. Some patients are chronic beyond treatment. So this is again switching from anti-VEGF to corticosteroids. Like Dr. Sharif has mentioned, there is no direct correlation between the central macular thickness and the visual acuity. However, those patients who switched from anti-VEGF to steroids did show improvement in visual acuity. Some of them, of course, like we said, and of course more dryness. So to answer a question, switching in persistent DME is a valid option, yes, and I will skip the laser treatments, but just want to go to the take-home messages here. So switching from one anti-VEGF to the molecule to the other should be exercised with a lot of skepticism. It's not a magical solution. Patient might need more than just a switch to improve, and it can go both ways, from aflibercept to other anti-VEGFs. Consider other factors that might be involved in an inadequate response, like the systemic control of the diabetes. Consider clear definition of a response and fading of a response. Consider the time of switching. After 3 injections, 6 injections, there is no magical number. You have to judge the patient individually. And switching to different class altogether might be needed sometimes, like if you decide to go to steroids. Thank you very much.
Thank you, Dr. Mohammed, for adding another important issue that we always face in our practice, which are the resistant cases and non-responders. And I hope we will discuss this further after Dr. Hani Hamza's talk.
Thank you very much, Dr. Khaled. Thank you, Dr. Mohammed and Dr. Ahmed Souka. The last talk in this session would be about the surgical management of DME. And before we proceed to the surgical management of DME, we just gonna revise quickly the multifactorial pathogenesis of DME, in which hyperglycemia leads to the formation of these advanced glycation end products. On one arm, we have that these glycation end products modify the structure and function of proteins and lipids and DNA, damage pericytes and endothelial cells, and this leads to the non-tractional component of DME. On the other hand, we have the promotion of mechanical changes in the vitreous and the vitreoretinal interface, and this forms what we call the tractional component of DME. So we have two separate components, a non-tractional one and a tractional one. What's the rationale of surgical treatment of DME? Even with the availability of multiple therapeutic agents, cases of refractory DME continue to challenge physicians. It has been noted long time ago in the 90s that PVD improves or clears diabetic macular edema. This has been reported by Nasrallah in the 90s. And in tractional diabetic macular edema, the release of mechanical distortion of the retina caused by the hyaloid or the epiretinal membrane, or even the internal limiting membrane, can lead to improvement of this edema. While the theories behind the rationale for the non-tractional component of DME have been many, and includes removal of these advanced glycation end products from the vitreoretinal interface, removing the abnormally attrient vitreous that could promote the DME, elimination of free and bound VEGF and cytokine loads which promote breakdown of the blood-ocular barrier. And finally, it has been shown that following vitrectomy, the oxygen concentration in the vitreous increases tenfold, and this by itself can inhibit VEGF and reduce macular edema. So these are briefly the benefits of vitrectomy in the non-tractional component of DME. We have to classify the diabetic macular edema before proceeding to surgery. The tractional component, the tractional DME, we have DME with abnormal vitreoretinal adhesion and proliferation. And these can be subclassified into cases with taut posterior hyaloid, cases with vitreomacular and or vitreofoveal traction, similar to the vitreomacular traction syndrome, and finally cases with epiretinal membranes, whether these membranes are vascularized in PDR or non-vascular in the background and pre-proliferative phases. In the taut posterior hyaloid, the posterior hyaloid is mostly attached, forming a glistening layer with white stria in the hyaloid but not in the retina. On OCT, you have a low-lying partial PVD with diffuse intraretinal edema. In these cases, surgical intervention can be very useful, and it can lead to resolution of the macular edema, and this is one of the clear indications for vitrectomy in these cases. The second subcategory in the tractional component is patients with vitreomacular or vitreofoveal traction. And in these cases, we have an uneven partial posterior vitreous detachment with vitreomacular attachment exerting a vertical traction component, as we can see in the OCT on the upper right side. And this causes foveal distortion and retinal elevation. Again, this is one of the very clear indications for vitrectomy in diabetic macular edema, and we will discuss later the factors for improvement, whether these patients will improve or not. Finally, we have another category, which is epiretinal membranes, whether avascular or vascular, and these patients have opaque white membranes plus minus vessels, PVD, which is partial or complete, but we still have this adherent thick membrane on the retinal surface, retinal stria and vessel distortion, and finally on OCT you have this hyperreflective membrane. Again, removal of these membranes can lead to visual improvement, and this is a clear indication for vitrectomy in diabetic macular edema. In some patients who had previously a vitrectomy and they still develop macular edema in the post-operative phase, we have a taut ILM syndrome, and in these cases the ILM actually exerts traction on the retinal surface, and it has been reported in many cases of literature that removal of the ILM in these cases can lead to improvement of the diabetic macular edema. Finally, we have the recalcitrant non-tractional diabetic macular edema, and in these cases there is no traction whatsoever, no response to anti-VEGFs, and here we have the $1 million question: how many injections? In my opinion, if you do 3 anti-VEGF injections and switch to steroids and the patients still do not respond, this is a non-responsive diabetic macular edema. Others consider 6 injections, but on the other hand, which patients will be so patient with their physician to wait for 6 injections without a response? I think this needs to be contemplated and thought over. The results of vitrectomy in these cases are anatomical improvement, yes, in many cases, but functional improvement in only 40% of cases. So before we proceed to surgical treatment, we have the preoperative evaluation to know whether it's a focal, diffuse, status of posterior hyaloid, and the vitreoretinal interface. And the surgical plan includes vitrectomy, PVD, peeling of the epiretinal membranes, and ILM peeling is an option as well in these cases. So let's go through some of these cases here. This is a patient with taut posterior hyaloid and diabetic macular edema with some hard exudates in the macula. The use of triamcinolone is essential because in these cases you may have a vitreoschisis and a layer of the posterior hyaloid. You engage the posterior hyaloid, and usually I prefer to engage it in the area of the papillomacular bundle where I have the premacular bursa. And once you elevate the posterior hyaloid in these cases, you release the traction. You can see now this is the elevation of the posterior hyaloid, inducing the posterior vitreous detachment. And now in this same patient, following the detachment of the posterior hyaloid, you apply the brilliant peel dye, use the diamond dusted scraper, and then you peel the ILM. Peeling of the ILM actually is an option in these cases and is not mandatory. If you find residual retinal stria after you do the ILM peeling, then in these cases, after you do the posterior vitreous detachment, then removal of the ILM is preferred in these cases. This is the pre and the post-operative picture of the same case, and this is another similar case. Again, injecting triamcinolone. Where is the mouse? Yes. And inducing the posterior vitreous detachment. Again, peeling of the ILM. And in this case, this is a patient with a taut posterior hyaloid. Again, following the triamcinolone staining, I still have a layer of triamcinolone on the retinal surface, as you can see. And this affects the staining. So you have a patchy staining on the retina. Peeling of this taut posterior hyaloid and an epiretinal membrane, and I still have this small residual part on the fovea, which I removed very cautiously. You can notice that there is some bleeding in the periphery from the PDR, and this necessitates that you do a PRP at the end of surgery, which reduces the VEGF load in the post-operative period, and at the same time, of course, reduces the diabetic macular edema. So at the end of the procedure, I did a proper PRP up to the retinal periphery. Otherwise, patients may progress with persistent diabetic macular edema and even rubiosis in the post-operative period. This is the pre and the post-operative picture post-vitrectomy. In this patient, we had an epiretinal membrane, and this was a case of chronic diabetic macular edema with this epiretinal membrane as well, and PDR. And again, these membranes are usually multi-layered, and while doing the peeling of the posterior hyaloid, I could remove the epiretinal membrane with it. It was adherent to the posterior hyaloid, and at the end, you do the ILM peeling as well. Finally, this is a case of PDR, and you notice after dissection the presence of these striae on the retinal surface. Again, peeling of the ILM in these cases can release the traction and help in restoration of the normal retinal anatomy. This is a residual area of proliferation which has been dissected at the end of surgery, and you do a very proper PRP at the end. Now the results. Visual results for non-tractional diabetic macular edema depend on the extent of vitreomacular traction, whether it's a broad or focal adhesion, duration of traction. In chronic cases, the prognosis is worse. Status of the outer retina, and this is very important. If you have disorganization of the photoreceptors, you will not have any visual improvement despite all efforts. Post-operative restoration of retinal anatomy. Post-operative chronic macular edema, which develops in some cases and compromises the result. And finally, the macular perfusion, since ischemic cases will not improve as well. While in non-tractional diabetic macular edema, we usually have a modest response of 40% in the best case scenarios. Anatomical results do not always correlate with functional results, and this has been studied by the DRCR study in 240 cases, and they showed that anatomic improvement correlates with worse baseline vision, worse central subfoveal thickness on OCT, presence of vitreoretinal abnormalities as vitreomacular traction, and ILM removal. But this is only for anatomic improvement, while visual acuity improvement was correlated only with worse preoperative visual acuity and epiretinal membrane peeling and not ILM peeling. Again, I remind you, anatomical results do not always correlate with functional results. There are two important causes of failure we have to keep in mind. Failure to detach the posterior hyaloid or leaving remnants of the posterior hyaloid that can lead to recurrent traction and chronic macular edema, and again, destruction of the outer retinal layers, as Dr. Magdi Musa mentioned at the beginning, and this develops in chronic diabetic macular edema and may urge for earlier intervention in these recalcitrant cases. Thank you very much.
Tureni, I have one question for you. I think it's really important when you're making a decision to go into vitrectomy in those patients that to differentiate accurately between vitreomacular adhesion and vitreomacular traction.
Yes.
Because sometimes you see those attachments of the posterior hyaloid over the macula, and you don't see actual anteroposterior traction. The foveal contour is maybe a little bit convex, and those patients can still respond to anti-VEGF treatment. I mean, you shouldn't just to deliver a message, you shouldn't just jump to
yes.
The surgery in those patients, because a lot of them, they respond even to anti-VEGF injection. Yes. If you're afraid that the membrane might contract, if it is a membrane, maybe you can try steroids in those patients. So I think because the results that you've shown that only 40% of non-tractional diabetic macular edema, only those patients showed some improvement, I think the decision to go into surgery in those patients should be really based on a clear definition of what's a traction and what's not.
Yes, you just said a very important word, a vertical traction component, which is, yes, anteroposterior traction component, and this should be looked for. Another important point is the biomicroscopy, especially in cases of taut posterior hyaloid, that you see this glistening sheen and the stria in the posterior hyaloid, and you may miss it on OCT, but clinically you can see it.
Thank you very much, Dr. Khalid and the EGVRS team, a wonderful symposium. I have just two simple questions. If the patient is having a significant macular edema and the blood glucose level is not controlled, do you give enough time for the control or you proceed for injections? This is the first question. Second question, if the patient is presenting with persistent proliferative and new vessels on the iris, as we see that on glaucoma, despite of good PRP and repeated injections, do you consider peripheral retinal cryotherapy nowadays or not?
I think the first question was answered in the lecture of Dr. Sharif Mbabi. Yes, we must give a chance for control of blood sugar before rushing into injection. But you disagree?
Yeah, I disagree in one point. In all cases, you have to advise your patient of control. Yeah. But most of our patients, they don't follow those advices. So the recommendation is you have to go both ways together. So you tell the patient to adjust his blood sugar, and we're talking about patients with drop of visual acuity, not the case that Dr. Sharif showed with 6/6 vision. So you have patients with drop visual acuity, center involving diabetic macular edema, hemoglobin A1C of 10, for instance. You inject the patient, ask the patient to control his blood. You don't delay the injection, because even if the patient is getting his blood sugar controlled, rapid control is associated with worsening of the edema in most of the cases. So you have to go both ways. Maybe Dr. Khalid is referring to the case of Dr. Sharif, that this is a patient with very good, excellent visual acuity and center involving diabetic macular edema. You can just tell them to control their blood sugar and wait for the injection.
I think it's simple, the guidelines. You have the indication to inject, you inject, and you advise the patient to improve his medical condition. If he is in the area of 6/6 vision and there is macular edema, it's a protocol V patient that you should go for observation, and you still advise him to control his medical condition. This can help that he becomes one of these 2/3 or 3/4 who do not need injections over the 2 years, but never delay injection for significant indicated macular edema for injection. Go for it.
Is there a role for peripheral retinal cryotherapy?
There is definitely room for it, but if the case is lasered heavily and injected anti-VEGF injections, and you have something persistent, the cryo will not make it go away. Because the injection of anti-VEGF is even better than cryo application of the periphery in reducing the VEGF level. If it doesn't respond to an injection, I will definitely not do a cryo. If it responds and recurs, I would consider stabilization by adding the cryo.
I think at this era, we need this procedure, peripheral cryo, but in very few cases, because now we are able to do, we have the tool of anti-VEGF, and we are most of the time able to do good laser, and many of those eyes would probably need vitrectomy. During the vitrectomy, you do endo laser. It's better, I think, than doing peripheral cryo for those eyes during, like when we were afraid to do vitrectomy.
Yes. Thank you.
Let me ask you for two or 3 minutes just to wrap up all this information for احنا عرفنا بوضوح. Unless there is somebody is different in the panel, I would like to say that we know clearly from Dr. Magdi Musa that OCTA is not replacing fluorescein angiography, and initial examination for a diabetic patient, you have to have a baseline fluorescein angiography, conventional fluorescein angiography, and OCT, structural OCT. And we know that laser, you might hear in laser خلاص راحت عليه ما بقاش موجود في الماكولار edema. This is not the case. Still, focal laser has some role in macular edema, especially in our country with the well-known financial burden of the injections. Medical treatment برضو دي مهمة جدا جدا. I re-stress ان احنا we all of us we agree ان there is no role for systemic medical treatment. لا دوكسيوم ولا غير دوكسيوم ولا كل الكلام ده ملوش اي دور في الدايابيتيك ريتينوباثي. We have to re-agree about this once more. The role of PRP, maybe Ahmed Souka may be different, but the role of PRP is still there. You do agree, then we all agree that the role of PRP is still there. لحد النهارده ما نسمعش او مش موافقين على انه بالذات في ظروف برضو في ظروف بلدنا مش موافقين على انه ال PRP is going to be replaced by injections. The role of steroids is limited. والlimitations have been mentioned, وما هواش الحل السحري للresistant cases اللي اتكلم عليهم quite well دكتور محمد مغازي. عندنا ما زال عندنا لحد النهارده مشكله في ايه اللي نعمله في الحالات البور ريسبوندرز. احنا مختلفين واحنا بيننا وبين الواحد مع نفسه ممكن يتصرف في تصرفات مختلفة according to the different patients. Sometimes we switch after the third injection. Some of us we switch to another drug بعد the 6th injection. And as we mentioned, as we heard from Dr. Hani, انه doing several injections would lessen the chances for surgery. So some people would consider surgery after 3 injections. I'm not especially for this choice, but it does exist. Resistant cases كمان ممكن one of the switching options is steroids. Some of them are very expensive, some of them are cheaper اللي هو الالترامسينون. وبالتالي الريزيستنت كيسز لحد النهارده مشكلتهم ما اتحلتش تماما. وواضح من الكيرفز اللي وضحها الدكتور مغازي انه الناس اللي بيبقوا initially good responders remain good responders. الناس اللي initially poor responders, most of them remain poor responders. Few are become good responders after switching, not all of them. عندنا مشكلة الرول اوف سيرجري. مشكلة الرول اوف سيرجري دي مشكلة مهمة جدا. I think it was very well clarified, but let me stress points مهمة جدا انه ما ينفعش ان احنا نقرر operation according to OCT. We don't treat OCTs, we treat patients. This is very important. Sometimes في حاجتين في النقطة دي. أول حاجة ال OCT reports لما بندي نفس الصورة واحنا عملنا study في رسالة ماجستير في الموضوع ده، لما ندي نفس الصورة لناس كتير من اللي بيكتبوا لنا OCT reports, many of them experienced ones write different reports describing epiretinal membrane situation في الماكولار إديما. وبالتالي ما ينفعش ان انا اعتمد على الريبورت المقروء ده حتى لو انا ببص على الصوره كويس ولا اعتمد على الريبورت. ما ينفعش ان انا ابني القرار الجراحي على نظرتي للصوره. الديسيجن فور سيرجري is not based on OCT. Please, I'm repeating this once more. كمان الدكتور مغازي لما ذكر في إنه some of those cases where you think there is a traction and the traction is the key, or removing the traction is the key to solution. Some of those cases عرفنا الكلام ده منين؟ لأن some of those cases reject surgery and they get injections and it shows that injections improves them. Some of these eyes. وبالتالي ال variations are many. Crossroads are getting less. في حاجات كتير ابتدت تبقى واضحه بالنسبه للبرود ديزيز اللي هو diabetic retinopathy، لكن لسه عندنا questions. مش عايز ادخل في التكنيكال ايشوز اللي اتكلم فيها الدكتور هاني لان they are too specific. هل يا ترى to remove the ILM or not to remove the ILM؟ هسيب النوع ده من الاسئله التكنيكال للجلسات المتخصصه. وبنشكر الشانس اللي الجمعيه التعليم المستمر ادتها لنا كجمعيه الشبكيه to pinpoint those important points. Thank you very much.